everyone, welcome to the channel Knowledge Star, Continuous Knowledge Excellence. My name is Nisha Masroor. In this video, we will get to know about, as a nurse, what to do while seeing a patient for the first time. Now, Dr. Deena Shah, who is the Director of Emergency Medical Services, Delhi NCR Fortis Hospital Limited, will explain to you in detail about this topic. So to get complete information, watch full video without skip.
How will you do actually when you are seeing the sick patient in front of you instead of feeling panic? So first, I'm sure many of you might have done a little basic, but the approach remains same. If you've done ACLS or ATLS, it teaches you the same. First, you check on the airway, talk to the patient. That was step 3, right? Talk to the patient. Is he got a clear airway or he is not having clear airway? If it is not clear, then you open the airway, clear the airway, and then you have to maintain the airway with various things which you can learn in one of the workshops, which probably they can plan and arrange as a coronary to this conference. Breathing assessment. After you see airway is patterned, patient is not making any noises, you go on a breathing assessment. On that breathing assessment, you assess 3 things. How much rate patient is breathing? What is the saturation? Do I need to give oxygen? And how am I going to give oxygen? That is also very, very important, because everybody, you should not give oxygen. We'll talk in detail as we go through. Third portion is when you see the monitor, you will see one of these parameters. And you will understand this is not right. What is not right here? Pressure is not right. Airway problem. Saturation is not right too. So always have your eyes first looking for oxygenation, then on the pressure. So giving oxygen is very quick and very, very important to keep everything alive, and then you support the circulatory problem. So how will you manage the shock? I thought I'll give you in a nutshell, very quick idea about the shock. For managing the shock of any kind, you have to remember only 3 things. Every shock comes into that definition. 1, pump, means heart. 2, the trunk, means the main arteries, pulmonary and coronary, aorta. Main pulmonary artery and aorta, and the 3rd is the pipes, the peripheral arteries. So if you look at these 3, whosoever is in trouble, you get one of the shock: cardiogenic, obstructive like pulmonary embolism, hypovolemic if the leaking pipes are there, and distributive if there is a septic shock or anaphylactic shock. Right, that is distributive shock, or pancreatitis and septic shock are distributive shock. So that's how you can remember the shock. What do you have to do in shock? When blood pressure is low, try to give little fluid and then go on the inotropes. Ensure your oxygenation is okay, then only you can cover the shock. Going on to the 4th, disability. Once you are assessing disability, to do it quickly, because whenever we are in crisis, if we are not familiar doing GCS daily, you can quickly use this to assess whether patient is alert, responding verbally, talking to you when you give pain stimuli, or he is not responding at all. And this is the language you can write that on neurological assessment he was V. Means he was verbally responsive when I saw him in the ward. When I transferred, he become not verbally responding, he becomes painfully responding, meaning GCS or alertness is deteriorating.
Wait. Are you worried about your project, training, dissertation, internship? Don't think too much, because Nanoscience and Technology Consortium, in short NSTC, is giving you a golden opportunity to do the same tasks. NSTC also conducts workshops on amazing topics. So if you want to register in the workshop, the registration link is given in the description box below, or you may go to the website www.nanoschool.in, where you can easily enroll in the workshops. So just check it out right now.
This is also very important for anybody who is under neurological assessment. If your patient says, I'm not okay, I've got a headache, I can't move these, then remember the stroke, because it can happen in CCU, neuro ICU, ward, anywhere it can happen. with any critically ill patient in ICU. Even it's not always ER and the peripheral people sees the stroke. In hospital stroke also happens, and the like 54 to 60% stroke happens nowadays in hospital. So you have to remember the fast, because you have to act fast. There's a mnemonic, okay? And the fast meaning facial droop, arm drift, speech, and you have to consider the time 0. So that's when you see them having those symptoms, facial droop, arm drift, unable to speech, or speech is unclear, you have to consider them going through the stroke, and you have to activate your stroke protocol in the hospital, and that comes on you because you are the first attendant of that person standing on the bedside. Last one, once you assess any crashing patient's airway, breathing, circulation and disability, everything is okay, but he doesn't look okay, then you should expose them and see whether he has got any rashes anywhere. Because sometimes we are dealing with a fever, we ignore rashes coming on the body because they are covered nicely, and that where you lose the sign of meningitis, because it's very obvious visual sign before even you see the neck rigidity on them. So that's why you have to be very careful. Of course, when you're dealing with a trauma patient, signs of other injuries under the covered area are important as well. The third bit is an abuse. Whenever you are dealing with a vulnerable age group, child, elderly and pregnant patient, if you see the bruise coming up, they are not okay, you see the bruise coming up on the neck in the ICU, you have to remember that they are not okay, they are altered sensorium because they are strangulated, or they are called shaken baby syndrome. Some child keep crying and they shake them to keep them quiet, and they become altered sensorium. They bring the child as an altered sensorium. You are thinking of lot of stuff where you miss the child abuse. So you have to see the signs of abuse in them when you deal with a crashing patient. All right? So remember, you not only do assessment, you do assessment, find out the problem, take action, go back and see them again, reassess them whether your action has worked on them and it has improved them or not. This concept has got positive outcomes, so it needs to be introduced. Even if you are alone, you have to call for help so people can come in and you can deal with it together. That's why the team resuscitation always have a better outcome, studied multiple time in multiple platforms in various countries. So that is why whenever you are having sick person in front of you, once you identify, you have to call for help. Don't start dealing with them alone, because any stage they just give up because you can't cope with them, and then you got no help. And then what you do is you run out of the cubicle or the room to get for the help, leaving that sick person who is about to collapse or lose the pulse alone in the room. That is not needed. That's why you should have different ways and means of calling for the team, which we will see in a minute. Another thing which one should practice to deal with them is a simulation. So whenever you are training your staff, you should teach them on the simulation methodology. Give the scenario, run it on the mannequin or somebody as a practical, as an artificial thing you can run, like practicing cannulation, practicing assessment, practicing dealing with a various shock management, practicing dealing with arrhythmias like ACLS, ATLS and stuff like that. Along with that, if you do not do that stuff, you can still do airway, breathing, circulation, simulation training in the department as well. Word of caution I would like to touch. Okay, so word of caution, when you deal with a geriatric patient, remember we put the bands on them to identify them and to notify the receiving other area that they are vulnerable age group. Why they are vulnerable? Because they do not behave the way normal adults behave. They will not have signs of shock the way you see because they are on multiple medication. Signs of shock, you think that is tachycardia and hypotension. They will come with bradycardia and hypotension. They will not raise their heart rate because they are on beta blocker, calcium channel blocker and lot other medications. So you will miss those signs when you deal them. So if you are seeing any vulnerable age group patients, especially the geriatric group, you have to be more cautious and more careful and more vigilant Same goes for the new babies. Whenever you deal with them, be it in emergency, NICU, PICU, wherever you are dealing with them, you have to be doubly sure for managing oxygenation, blood pressure, and the most important for them is a temperature. The moment you open them to assess, they lose their temperature and they become hypothermic and they develop lots of problems in terms of brain hemorrhage, necrotizing colitis, and rest of the other stuff which will give them long-term morbidity and mortality as they grow older. So you have to be careful.
I hope you liked the video. If you want to see these type of videos, please do comment. We will definitely reach out to you. Thank you.
For more updates, subscribe to our channel, click the links shown on the screen to stay connected.